Welcome to the Challenges in Global Mental Health panel discussion. My name is Deepa Rao. I am faculty in the Department of Global Health, and I'm the co-director of the program on global mental health, and I co-direct the program with Jane Simoni and Jürgen Unützer, who is on our panel today. Just to let you know, Vikram Patel, Jürgen Unützer, and Debra Kaysen will be introducing themselves. We've given them some time to explain some of their work to you. So with all of that, I will hand the mic over to our panelists, and they can introduce themselves and tell you a bit about their work.
Okay, well, good afternoon, everyone. And first of all, I'd like to thank Deepa for having started this meeting to make me feel at home by making sure the sound didn't work. Coming from India, that definitely makes me feel at home here again. But I'd also like to thank the South Asian Institute for, is it South Asian Center, sorry, and the Department of Global Health for hosting this panel discussion. I should acknowledge that my own transport to be here was thanks to the Institute for Health Metrics and Evaluation, which some of you know is part of the university. Global Health Division. I serve on the Scientific Oversight Group for many years now, and I come here every May for our annual meeting. So Deepa has asked me specifically to say something about my work in South Asia, so that's what I'll do. But I'll just start by saying, first of all, that I'm a psychiatrist, but have spent almost all my career working in the area of public health, first for some years in Zimbabwe, and then for the last 15-odd years in India. I live and work in a state called Goa, which is on the west coast of India. It's not usually the place associated with academic work, but that's just therefore a good reason for me to find myself there. It's actually a place more well known for beaches and hippies. As you can tell, I'm neither. I'm not, but actually I'm not a hippie, but I like being on the beach. In Goa, I work with an NGO, which is a community-based nonprofit kind of setup. India is a rich place for, as South Asia is, for civil society organizations, and many areas of public health, which is a huge gap in India and across all areas of health. Many areas of the gaps are addressed by NGOs, by nonprofit organizations. And mental health is a very good example of one of those very big gap areas in public health, which has been filled to some extent, only to a small extent, by NGOs. And that NGO is called Sangat. It started off as an agency to work with children with developmental disabilities because there were no services for kids with these issues, but has grown since then into becoming one of India's premier innovators in developing interventions for mental health problems. And its central innovation is using of ordinary people to provide mental health care, for which it has become extremely well known. So the idea is quite simple. You change your whole idea from being under-resourced to being extremely well-resourced, because instead of looking for people you don't have to provide healthcare, you look at the people you have and see how they can provide healthcare. And so Sangat really sort of innovates across the whole range of mental health problems, from autism in children to depression in adults to dementia in older people. I also wear a couple of other hats. I'm the director of a new Center of Excellence for Mental Health at the Public Health Foundation of India, which would be the sort of equivalent to the School of Global Health or School of Public Health here in UW. It's based in New Delhi, but has institutes in 5 cities in India, each of which has got a task of developing regional capacity in public health research and action. PHFI recently launched a new Center of Excellence for all brain disorders, mental and neurological disorders, and I've taken over as the director of that center. So I'll be spending part of my time in Delhi from next month. Most people feel very disappointed to hear that, but I'll soon find out really how bad it is when I shift. For those of you who know what Delhi is like, I think you know what I'm talking about. And the role that I will play with PHFI is really capacity building, so really developing public mental health capacity, which is a part of the national healthcare system, because that's really where PHFI mainly works. And the third hat I wear is that of working with the government of India. I serve on 2 national level committees, both of which are concerned with some really exciting reforms in mental health care in India. The first is the Ministry of Health has a mental health policy group that it constituted last year to write a completely new vision for mental health care in India. And it was a great opportunity for me to serve on that because it allowed us for taking some of the research evidence on implementation, which I have to say partly is borrowed from what the kind of work that happens here in Seattle that people like Jürgen and Greg Simon have actually initiated a long time ago. So to take the evidence of that, of the work that we have done in India using those models of care and making them part of the national healthcare system. There's another committee I serve on called the National Rural Health Mission Advisory Group. This is the first time a psychiatrist has ever served on that group, and is also a signal that this mission, which has been primarily focused on maternal and child health, is now expanding its interest to address mental health. So that's also a very important sign, I think, of how mental health is being mainstreamed in national health policy. And a final word of introduction, I should say actually my job is in London. I'm not employed by any of these people. My full-time tenured job is in the London School of Hygiene and Tropical Medicine, where I chair the Center for Global Mental Health. How I managed to actually have a job in London and live in Goa, we can talk about if time permits later.
It's lovely. Hi. First of all, I want to thank all of you for being here. You have lots of things that you could do with your Friday afternoon. We don't have sun, but you could be out in the cloud today. So I really appreciate you taking your time and your energy and your focus to be here with all of us. I am a clinical psychologist. I work in the Department of Psychiatry and Behavioral Sciences. I also have adjunct positions in global health and in the Department of Psychology, and I work with Deepa and Jrgen in our growing global mental health group. In terms of the work I do, my area of specialty is working with trauma-exposed adults, and I spend a fair amount of time doing training, as well as doing research in that area and providing direct clinical services. Out of that, I was asked to participate in 3 different research studies in global mental health settings. And all of these involve taking empirically based interventions that we found work really well for trauma-exposed populations, but are seen as being very complicated and difficult to learn, and seeing if we can scale them and use them, and if they work in global mental health settings. So we finished the PIs are Paul Bolton at Johns Hopkins and Judy Bass at Johns Hopkins, and we worked in collaboration with NGOs, Heartland Alliance, and the International Rescue Committee. And we completed 2 trials, one in northern Iraq and one in southern Iraq for Iraqi torture survivors. And then we just recently completed a trial in the Democratic Republic of Congo for Congolese rape victims. And so I think I'm here in part to provide a psychology perspective to this. But one of the things that I appreciate is working with individuals at different levels of training in multidisciplinary settings to teach them how to do fairly complex psychosocial interventions, and then figure out how much training you really need to be able to do that well.
Good afternoon, everybody. I think we have some nice Indian snacks in honor of Vikram. So if you at some point, if you'd like to go find some, that'd be great. I'm Jürgen Unützer. I'm a professor and vice chair of psychiatry in the Department of Psychiatry here at UW School of Medicine. I direct a division in our department called Integrated Care and Public Health. This is a fairly new thing, in fact, less than a year old, and very exciting to those of us who think about what mental health care looks like in places where there are no mental health specialists. That's pretty much what we're about. I'm also an adjunct professor in the School of Public Health in the departments of Global Health and Health Services Research. I'd like to thank Deepa for getting us all together here. This is a typical Deepa thing to do. Deepa has really been the catalyst and the motor for getting those of us at the University of Washington who have an interest or a passion, and some of us a very long-sustained hobby in the area of global health and global mental health together. And it's wonderful. I also want to welcome Vikram. Vikram is a good friend. He is the most accomplished and influential figure in global mental health today. I can say this and I have no doubt about it. And it's really great for us to hear from him and have a chance to talk with him while he's here for the IHME advisory board. So this is supposed to be a discussion, so I'm not going to say too much. I am going to put out a few pieces of information and a couple of observations about global mental health to help us get started thinking about this. Just a few numbers. Just about 1 billion people worldwide suffer from poor mental health in one way or another. That's a lot of people. This is not a sort of a small, sort of rare problem. Poor mental health and substance abuse will not only rob you of the ability to have a productive life, they are in fact responsible for, and this is IHME work, 25% of all the disability that people have related to health conditions worldwide. Depression alone, which is one of the common mental health problems we have, is responsible for 10% of years lost to disability worldwide. There are 1 million suicides every year. And just in this country alone, every 14 minutes, somebody takes their life. These are not rare problems. And if you looked around, if you haven't had an experience with a mental health problem yourself, I can guarantee you, you have family members, you have friends, and you all know this, and we don't have to do raise of hands. But these are not rare problems, and they're everywhere. There is no society in the world that doesn't have a huge burden from the common mental health conditions that we work with. It goes more than just mental health. Mental health and the rest of health are incredibly related. So, for example, big cause of mortality is accidents, is injuries, is homicides, and there is a huge link between mental health and substance abuse problems and those kinds of conditions. In fact, well over half the suicides in this country, for example, there is a substance abuse component to them. So these things are all connected. If you have diabetes, if you have a chronic medical condition and you develop a serious depression on the top of that diabetes, you're going to be less adherent to your medications. You're going to be living a less healthy lifestyle, and you're going to have a much higher mortality rate related to that depression. So even if we don't care about depression, for example, there are lots of other good reasons, if you think about overall health, for us to be worrying about mental health. I'm going to give one more example. One of the reasons why the burden from mental health problems are so big is they start very early. So there are other diseases that we worry a lot about in this country, cancer, heart disease, but those are things you start getting when you're in your 50s and 60s. Mental health problems can start when you're born. So for example, if you are an unborn child and your mother got serious depression, or anxiety or drug use or some serious mental health problems, and you're spending 9 months in an environment where your brain, as it's trying to develop, is exposed to things that make it very, very difficult to have normal brain development. And then when you're born, you're going to be a fussy baby. I'm not doing this in a very sort of technical way, but now you have a seriously depressed, anxious mother who has a very difficult life circumstances with a really fussy baby. And guess what happens? They're going to have a hard time sort of making it through the first 6 months together, and the mother is going to really struggle. And we know a lot about how important those first 6 months of that first year is for the baby's brain development, for their social development. If you don't have good attachment there early on in life, that baby has a much higher risk for having his or her own mental health problems as an adolescent and all the way into adulthood. So these are things that can start very, very early on. So that's the bad news. The good news is these things are not fatal. Actually, mental health problems per se don't kill a lot of people. They're just tremendously disabling, and there's actually a lot we can do. So we can do all kinds of things. You can do things like addressing the social determinants of health and mental health, poverty, violence. If you're in public health, there are lots of ways in which you could actually be doing mental health work, even if you don't think of yourself as a clinically trained mental health practitioner. You can prevent things like depression. So if you have a nice way of helping that depressed mother, right during her peripartum period, you might make huge differences in prevention down the road. And you can treat it. So a lot of the things that seem terribly difficult, like a person who has serious post-traumatic stress disorder, you can treat that. And the kind of work that Deb does, not only here in Seattle, and she has treated some of our most sick patients, and it's amazing when you see somebody who has serious post-traumatic stress disorder come back and they become a different person, they get their life back. It's life-changing, it's really magical. And what Dept has shown us, you can not only do that here in Seattle, she can go train folks in the Democratic Republic of Congo to do these very same treatments and get very, very good effect. So that's the upside. That's why I think it's exciting for us to think about doing work in global mental health. Now, there aren't enough Debra Kaysens in this world, not even in Seattle, and that's a challenge. We're never going to have enough mental health specialists anywhere. In fact, I'm a psychiatrist, so if you thought you needed a psychiatrist to fix all the mental health problems in the world, it'd be a long time. So there are more psychiatrists, for example, in the city of San Francisco, which is 7 square miles, less than a million people, than there are in the entire continent of Africa, which is over 1 billion people. Here, we don't have to go to Africa. We're up here, the only medical school in a 5-state region in the Pacific Northwest that serves just a little over a quarter of the landmass of the continental United States. And more than half the counties that we do our work in have never met a psychiatrist. So even here, we don't have to go very far. We don't have enough specialists to take care of problems. So we've had to become very creative. We've had to think about who all else could be a mental health worker. And it starts with the patient, and it starts with their family, and it starts with people who are in their life. And we start looking at treatments. So helping a depressed mother, you don't have to be a psychiatrist. Maybe you need a psychiatrist at the very tail end when that mother is really struggling and you've tried a bunch of other things. But we've gotten very creative, I think, and we think about what are ways in which we can create human responses, organized human responses to things that have been around for millennia. Depression isn't a new thing. I think it's been around probably as long as mankind. And people have always had organized human responses to this. And I think some of what I get out of doing work that's not just in Seattle, that looks at what happens in other settings, it's not just about us here in Seattle exporting neat things that we found to somewhere else. When you go and look at very low resource settings, there are just as many depressed people there, maybe more. And people are doing some very creative things. And if you took a really careful look and see what happens there, sometimes we get some fabulous ideas that we could actually bring back and try to help make our healthcare delivery systems better and certainly more cost-effective, because we are not known in this country for, being the most cost-effective way of treating any kind of health problem, including mental health problems. So those are some reasons why I think this is a fabulous, fabulous field to be in, and it's really wonderful to see this many students here trying to, learn more about global mental health. I think I'm going to stop with that. Thanks to Deepa again for pulling us together.
Why don't we go ahead? Should I go ahead with the list as ordered? Okay. So the first question on the list was part of a series of questions, but I thought it was kind of nice to ask it first. But what is your perspective on the greatest challenge to the global mental health field at this point? What do you think is our greatest challenge?
Let me kick off. I think the first thing is I'm not sure actually who's in the audience, in the sense, are we mainly global health? Is South Asia?
Total mix.
It's a total mix. Okay, good. All right. That makes answering.
From very senior faculty to undergraduate students.
All right.
Yeah.
Range of things people
That's great. Thank you, Jürgen. So it makes answering very easy. That's all I need to know. Yeah, very helpful, actually, yes. So I think, for me, there's two different questions hidden in here. One, I think what you're really asking, what's the greatest challenge in the field of global mental health, which I think is different from what's the greatest challenge to the field of global mental health. I think you meant the former, but it could have been the latter. But I'll take a pot shot at both. So what's the greatest challenge in the field of global mental health? I think is the same challenge in any field of global health, which is implementing the knowledge we have. I don't think it's discovering anything new or inventing a new technology or any such complex thing. It's actually just being able to do what we know better. And whether you look at vaccines or delivering psychological treatments, it's really the same challenge across all fields of global health. It's implementation in very weak and resource-stretched health systems. And I think, in fact, interestingly enough, the solutions also are very similar, whether it's delivering vaccines or mental health treatments. The biggest challenge is human resources. And at the heart of all the innovations in global health today, it's the idea of redefining who is a human resource for healthcare delivery. And maybe we can return to that in the discussion. But what's the greatest challenge to global mental health is interesting. I've been having a lot of discussions with Jürgen and Debra and others here, but also over the last several months over this incredible controversy that's brewing in the US, but also, I think, as a consequence more globally about whether or not these so-called psychiatric disorders truly exist, what the boundaries are, how they seem to be constantly changing in shape and form, and actually what the rationale for those changes are, and how much of this whole business is completely corrupted by the pharmaceutical industry. I say that's a huge challenge because just as at the time when actually there is an increasing policy recognition about the importance of mental illness, I fear greatly that this noise that is coming about the validity of psychiatric diagnoses may further postpone, further confuse policymakers about taking action. And I think that's another issue that perhaps we can talk about later. But Debra.
Just building off of some of the points that you were making, I think the other place where I see a huge challenge is for people to see this as an area of priority, for governments to see this as a place that is worth spending. I think often there's been a perception that these illnesses, that these disorders are not treatable, are not valid. I think there is a lack of acknowledgement around the costs to the individual and to societies. And I think without individuals and governments seeing this as something that is worth investing in to improve public health globally, I think it's going to be very difficult to make changes and to implement what we know.
Maybe a little provocative. So I think the biggest challenge to global mental health is people like ourselves. We're many of us are researchers. We're kind of eggheads. Some of us in mental health are more on the introvert side. We don't self-promote terribly well. And I think actually, if we spend too much time worrying and airing our dirty laundry about what we don't yet know, it could get us in some trouble. I think we should be very good at articulating how we can change someone's life. People like to do things and like to get behind things that make a difference, that can really change someone's life. If we can say, look at this dynamite thing we did for this person or for this group of people, it really changed their life. People get excited about that. People want to put more money behind it. Clinicians want to train it. Why do people not go into mental health clinically? Because they're not so sure that we have something really exciting to offer in terms of treatment, in terms of help. If we feel strong about what we have to offer and we get better at that and we articulate that very well, it can make a huge difference in getting this on the right agendas.
Okay, thanks. And then kind of as a natural follow-up, the same person asked this next question. Where is global mental health on the development agenda currently? Where has it come from and where does it need to move to? So kind of this seems to connect with what you were saying, Debra, about there's not enough attention paid, I think, to this particular area.
Well, no, I can just simply speak to one point, and I think we can all have our views on this. Well, yesterday, the World Health Organization passed the Comprehensive Mental Health Action Plan. That's where mental health is on the global development agenda. It's right at the top yesterday, alongside two other action plans that were passed, one on blindness and one on non-communicable diseases. So you can begin to see, the latter two are, very obviously don't have much problem creating public acceptance for. But to have mental health alongside blindness as a global action plan, I think tells you a little bit about where mental health today has reached. And I think the second part of the question, where does it come from and where does it need to go? I think it comes from an incredible body of evidence of exactly the kind that I think Jürgen referred to in his last remarks, the evidence that, in fact, you can do something. And that to do something, you do not need to build an outrageously expensive specialist-led healthcare system, although it would be nice to have more specialists, there's no denying that, but we don't have to wait until we actually have more specialists to be able to address mental health care needs. And you can actually do things even with the very few specialists that many countries have. To me, that's been the game-changing evidence, the evidence of effective interventions, and more importantly, that you can actually deliver these interventions even in low-resource settings with very good benefit.
I do think that maybe it's not in the development agenda where we, the three of us, would like to see it, but I think Vikram and I have been at this for a little while, and we've seen a huge change in where it is. Remember 10 years ago when you came and spoke to the Assembly, around World Mental Health Day when the big WHO report on mental health was released. Now we're 10 years down the road, and I think we just keep working away at this, and folks like Vikram actually have made a huge contribution to get it on the right people's radar screen. The other folks who have helped us, frankly, are Chris Murray and the folks who did all the work around the global burden of disease. They continue to show us that, in fact, mental health and substance abuse problems are the huge drivers of disability. And I think that has helped us in some ways more than, and getting it and keeping it on the agenda more than, a lot of other things.
Both of you have touched on the development, and both of you have been instrumental in the development of global mental health and bringing this more to people's awareness. I think one worry I have, there's a reason I study anxiety disorders, is seeing the impact of, and I know this is going to be one of our last questions, but some of the medicalization of mental health problems, seeing this as very biological or solely biological, I would see also as something that is an area of concern. And does tend to undermine this idea that we can do something about this, that these are not only manageable disorders, but these are in many cases treatable and curable disorders.
But how do you feel the new NIMH approach of research domain criteria, or RDocs, as articulated by the NIMH director Thomas Inzel, will affect our work?
And so there are sort of two pieces to this, and for those of you who have been following it. So one is that he disavowed the DSM, but also he said we need to be thinking more broadly in terms of mental health disorders. The other piece that's been happening increasingly at NIMH is a push towards prioritizing research that is more biologically focused and less psychosocially focused. Now, admittedly, I'm a clinical psychologist, so I think about things from a psychosocial and a biopsychosocial perspective. I actually think some of his ideas around looking at systems and looking broadly across disorders makes a lot of sense, and it makes a lot of sense clinically. Some of the strategies that we use work across disorders. I know if I treat PTSD, I actually tend to get a lot of improvement downstream. And we have lots and lots of good data that if you treat PTSD, you actually can change things like rates of violence re-exposure, depression, substance use, guilt, eating disorders. We've got beautiful data around that. So things are related. Oh, Deepa actually got it up for me. I'm not sure how well I can actually multitask that much. I can't. But it's good to know.
Deepa is from a generation just one smidge below us, so you can do it all. It's like you can probably rewrite the criteria while you're talking.
I do that. I would normally do that. But
Deb at least looked at it. I wouldn't have accepted the
you
phone.
wouldn't see. I tried for a moment. Plus, I was just reading that multitasking actually decreases learning. So there you go.
Right now, my students are all laughing because they all know I have no idea how to use this.
Nice. I think some of the danger is by just choosing one model to think about this, it prevents us from thinking about other factors that are also important and that we have lots of data are important. And as many of you probably know, with research dollars getting increasingly pinched, I think my worry is that really good research around implementation questions, for example. I mean, that's part of where we started was, great, we have things that work. How do we successfully get them out there and get them in the field and get them into the hands of the folks who are going to benefit? That one worry I have is that that line of research is actually going to get shut down.
Yeah, my perspective on the current, controversy around the release of the new DSM Diagnostic and Statistical Manual, I think in 3 years nobody's going to talk about that anymore. I think it's a total blip. I think that, I think we need to continuously improve the language and the labels and the criteria we use when we talk about what are we talking about when there is a mental disorder. But I think for the most part, in the big picture, there is a lot of consensus around the major syndromes, depression. Everybody has a pretty good sense globally what it is when somebody is persistently, seriously depressed. Bipolar disorder, people know what that is. Serious anxiety disorders, people understand what we're talking about. Chronic psychosis, schizophrenia, people know what that is, and it doesn't look any different anywhere. And I think there is a pretty good broad consensus on the big picture. I think some of the fine-tuning around, arguing about is it in, is it out, is it this, is it that, how many different kinds of versions of this or that disorder, that's like how many angels can you fit on the head of a pin. I think it's frankly not, it would distract us, frankly. I think we should be thinking about what are the broad disorders that we have real good consensus about, and what is it that you can do as an organized human response to those, and what are we learning from that? So I'm not a big fan of getting too worried, too stuck on sort of on those little details. And I actually think that 3 or 4 years from now, nobody will remember that DSM-5 is any different from DSM-4. And the truth is, the DSM is just a U.S. thing. The rest of the world uses the same category of categorization. There is the International Classification of Diseases, ICD, and they have a wonderful set of criteria for every single mental health disorder, and it overlaps quite a bit with what we see in DSM. So that's my view on DSM. I think it's temporary.
Okay, so I guess getting back to global mental health, I will ask potentially a related question. Just given the fact that, the NIH is having, and the U.S. government in particular is having, our sequester and funding cuts. And I know so much of our funds come from the NIMH to do global mental health work. What are some funding sources that you would suggest for global mental health programmatic and research work? What is, I guess, some flexible funding that you have utilized to support your work?
Well, if I'm going to tell you that, then I'm going to have more competition. So I'm going to be very careful about what I say here. Actually, I think that the biggest funder is just a few miles somewhere east, west, or north or south of here. But unfortunately, he and his wife aren't particularly interested in mental health. So I think really shaking the minds of people who control non-government money for global health. Let's not forget, of course, that government money is still the biggest. If you look at the overall pie of global health funding, foundations only play a small role. But nevertheless, foundations play a very big role when it comes to influencing the agenda of global health. And particularly the Gates Foundation, without a doubt, is the biggest daddy of them all. And I think it is going to be, I hope it's only a matter of time before the Gates Foundation begins to support mental health work. Over the years, they have gradually shifted from what was originally a very narrow focus on technologies for infectious diseases to then accepting maternal and child health and tobacco control. And just a couple of days ago, the discussion has now extended to primary care. And it seems to me you can't actually invest in primary care if you don't also consider integrating mental health. So maybe that's the most exciting option ahead, is looking at foundations. It has to be said, aside from the Gates Foundation, most of the other big foundations are now supporting mental health work. And so there is for example, just to give you one example, just a couple of weeks ago, a major new mental health research charity called MQ was launched in Britain. It has no nationality limits. Anyone can apply from any country in the world, and provides a full range of funding schemes for individual awards, from junior fellowships all the way through to senior fellowships. So that's just one of a number of new schemes that's available. And in case you're working globally, you should also keep in mind that in-country funders, I think that's another important thing to remember. There's a shifting balance of money. So many countries like China, India, Brazil, and South Africa now in-country resources. Mexico is another great example. So you don't necessarily have to find all the money as used to be the case in the US or in Europe. In fact, you can now actually find money in the developing world itself and fund some of your collaborative work through multiple sources, including funds that come from the South. Another example is the Qatar Foundation, which is actually even bigger than the Gates Foundation. It's in fact the biggest foundation in the world. And as Jürgen and I are involved with, this year they are launching a major new, what they call the Davos of Global Health. It's called the World Innovation Summit for Health. And of the 6 themes that they have identified that they would like to promote, mental health is one of them. So it's quite interesting how players who we never heard of before are actually appearing and supporting mental health.
In terms of the work that I've been involved with, it's actually been funded through USAID. And there is an impetus for some of their work that if NGOs are providing services, that they should also be evaluating whether or not those services are effective. And this has actually been a nice avenue for us to build research in and to test out new interventions or ways of implementing interventions that are helpful.
Just to add a few things. So I'm going to echo Vikram. If anybody here has any capacity to influence the nice couple that lives a couple of miles away from here to become the last foundation on the globe to start developing a mental health portfolio, it'd be really exciting. We're just a little bit kidding, but not so much. There is different ways of going after money, right? You can go in the front door when you're talking to somebody who has a portfolio in mental health, and there are some really exciting developments. For many of us in the U.S., this has been really a sort of a labor of love, a kind of a systematic long-term hobby, because there just really weren't good U.S. funding sources for doing work, sustained work in mental health. There is other funding for other kinds of global health. I will point out and give credit to the National Institute on Health and even the National Institute on Mental Health that actually in the last couple of years has created an initiative in global mental health. There is an Office of Global Mental Health. There is a person named Pamela Collins who heads up that portfolio. Pamela is a psychiatrist. She's a very smart person. She has been all over the world, and she has a very good understanding, I think, of some of the issues and where the NIH could make a contribution. So that has become a source of funding, and Deepa and I have a nice grant together where we're working with folks at the University of Nairobi in Kenya, spending NIH taxpayer dollars to try to help build research capacity in Nairobi. And so I think that's a nice thing. It's a nice development. It's good to know. And then there is the backdoor approach. And that is something we've had to do in mental health for a long time. You know, you tag your cause to somebody else who's got a lot of stuff going, has infrastructure, has money. So, you know, when I say, you know, a person who has heart disease and who gets depressed is going to have a higher chance of mortality, heart disease has more clout than mental health has any day. So it's a backdoor approach. I say I have to treat this person's mental health because otherwise their heart disease will kill them. It turns out actually we've done very well with that. HIV is another fabulous example. If you have HIV and you're not taking your antiretroviral medications, not only is that going to kill you, you might develop drug-resistant HIV, and then you're going to give that to someone else, and now you got a huge public health problem. That argument is even better in tuberculosis and other things that sort of spread very readily. So that's the backdoor approach, and I think some of us have been reasonably successful in sort of getting funding for our cause that way.
So I've been wanting to do this, but maybe raise of hands with the audience. Can you raise your hand if you consider yourself a student of the social sciences or a social scientist? Okay, so we're talking anthropology, sociology, political science. And what about public health? Okay, and what about mental health, that you're a clinical psychologist or a psychiatrist? So we've got a pretty even spread. So we had one question, and I've been hearing this question kind of echoed throughout the last couple of weeks. But how do you feel the social sciences, such as anthropology, sociology, political science, social work, and psychology can or will contribute to overcoming the challenges in global mental health? And maybe we could focus on the kind of the non-clinical social sciences.
So I think, in my view, actually, these are actually integral parts of global health. I can't even see how this question, global health is completely different from clinical medicine. And what differentiates global health from clinical medicine is, in fact, its fundamental interdisciplinary nature. So in my view, actually, these are all fundamental integral parts of global health. You can't actually achieve implementation without any of these disciplines. And so each of these disciplines contributes a very important, specific, complementary role in the field. And certainly if I think of my own academic group in London, if I consider that as one of the 3 academic groups that I lead, we have 15 staff, of whom only 2 are psychiatrists. All the rest are social scientists. And I don't think there's any global health field I know which isn't composed like that. There's usually a few biomedical practitioners, but the majority are drawn from a whole range of social sciences, not just one. Economics is one you don't mention there, but I'm assuming that must figure, and it does, yes. So, there's a whole bunch of different social sciences. And I think what makes global health so much fun is actually the fact that it is so interdisciplinary.
Yeah, I have nothing to add. I agree.
So I'm going to say some very concrete things. There's an enormous amount you can do as a social scientist to help advance this agenda. If you are a sociologist, anthropologist, anything along those lines. Help us understand the barriers to, why people aren't getting good care now. And it's not so much on the supply side, it's on the demand side. People aren't clamoring for better mental health care. People don't even know they want it or they need it. And when we put it in place, many of us who are in medicine and public health, we always create supply side solutions. We create neat things, and then we're kind of wondering why more people aren't using them. Or, Debra comes up with a new treatment. She trains a bunch of people on how to do, CPT, and maybe people aren't actually asking for that. So help us understand that demand side. What is it that we're missing here? Because if we create neat solutions and nobody uses them very well, that's a problem. If you're in social work, if you're in any area like that, help us think about how we can take on the social determinants of health and mental health. There is a huge amount of work that I think we could do if we were really smart about it. If you're an economist, help us make those arguments better that, in fact, from a purely economical perspective, a country should be investing in, all the way from social determinants to preventive to therapeutic interventions. If you're a communications person, help us communicate more effectively. We're pretty lousy at communicating some of what we've been trying to do up here. So if you're a filmmaker, if you're a writer, if you have a way to get to people's hearts and their minds, help us with that. There's tons of ways, I think, in which you can help.
And just speaking concretely, one of the really fun pieces with our project in DRC was that we looked at the economic outcomes associated with people finishing treatment. And how did this improve their life? How did this improve their children's access to food? That's a compelling argument for people about why intervention is important and helpful, right? But that idea never would have come up if we hadn't been working with people with a background in economics. So it becomes a richer discourse when we draw from each other's strengths and perspectives and work around each other's blind spots.
If I can just add something to what Jürgen just said, for those, if any of you have a good idea on how one can actually address this one very big challenge of increasing demand for mental health services, the New York Academy of Sciences has a sort of offshoot called Scientists Without Borders, and in another month or so they will announce they have these challenges which give a $10,000 prize to solve a particular problem in global problem. And in this case they have chosen exactly this particular challenge. How do you actually increase the demand for services for people with depression in low-income countries? So you've got a head start here. If you can come up with an idea, there's $10,000 waiting for you to be won.
Okay, so we just have a couple more questions, and then we'll take some from the audience. What is the role of our partners, and what this person means is bilateral NGOs, governments, and civil society, and what role can they play and need to play in this movement for global mental health?
So again, I think I'd give the same answer as I gave for the disciplines. I think it's, again, everything in health is about partnerships, partnerships between disciplines, partnerships between different agencies. But I think I want to say the one thing, a specific point about I think a partner that has largely been missing from global mental health, and a group that I personally have, over the last couple of years, started spending a lot more time focusing on. I see myself spending a lot more time focusing on. And those are the voices of people who actually have a mental health problem themselves. I think it's one of the most important things in the field of global mental health has been learning from other experiences in global health. And perhaps the best example of how the world galvanized into action over the last 2 decades in any global health field was, of course, HIV/AIDS. And if you chart the history of the transformation of HIV/AIDS, it's incredible. Only about 10 years ago, most people in sub-Saharan Africa had no access to antiretrovirals. It seems like distant history, but in fact, it was only 10 years ago. By which time almost everyone in the US had access to life-saving treatments. And until about 2002, for those of you who probably don't know the whole history, the general argument was that actually Africa's health system was too weak to support the kind of complex health system requirements for delivering antiretrovirals. So the dangers of giving antiretrovirals are even greater because people would not continue treatments, and et cetera, et cetera. And of course, the transformation happened. And if you look at the pivotal event, I think, about that transformation was in 1998 when the Treatment Action Campaign in South Africa was launched. And it was a completely consumer-led movement. It was basically a human rights-led movement led by Zaki Ahmad and others who lived with HIV and shamed their own government, shamed Big Pharma, and shamed Western donors for putting up all these false arguments that you could do nothing about HIV/AIDS. And actually, I think the mental health field is very similar. We deal with a stigmatized problem, a problem for which there is very widespread nihilism. You can't really do anything about these things, in spite of all the evidence that Jürgen and Debra have referred to. But I think, unfortunately, what's really the problem is, I think it's the three of us don't represent, in fact, the most powerful voice that can actually affect change. I think what is really missing in this movement at the moment are people with mental illness being organized to be more effective advocates. And I'll just end by saying that that is also now beginning to change. 2 years ago, a coalition of very small user groups, consumer groups in Africa got together under a large umbrella called the African Association of People with Psychosocial Disabilities. They have started now connecting with South Asian groups, Latin American groups, around essentially advocating for their own rights. I'm sure those of you who work in the disability area will know the well-spoken slogan, "Nothing about us without us." And I think until we really exercise that slogan in the mental health field, I don't think we're going to make that transformative change. That's the very important partner we need to work towards encouraging.
I agree totally with that. I'll just add one comment. Who are those people who have mental illness? Some of them are in this room. Some of them may be up here on this table. A lot of them are in this room. These aren't weird people somewhere. If you look around, if we had knew each other a little bit better and we felt comfortable with that, I'm going to tell you that 25% of the people in this room sometime in the last year have taken a medicine for depression or for some other mental health problem. A whole bunch of us have talked to somebody about our problems. It's us. It's not some weird group of people somewhere.
Yeah, absolutely. And there have been a number of very prominent researchers and clinicians in the mental health field who actually have publicly come forward around their own mental health struggles. And so my hat's off to them as well. So some of that is happening. I think one thing I want to also highlight is the importance of involving Ministry of Health. I know that that was listed. I agree with you that all of those groups that were listed are important. But having worked in some projects where the Ministry of Health was more integrally involved in the project and those where that was less true, I think the sustainability is more there when we have Ministry of Health involved from the get-go and have their buy-in. And I would be curious, Vikram and Jürgen, about your thoughts about that.
Well, absolutely, Ben. I think fundamentally, even though I've worked initially in the NGO sector, I think NGOs are only innovators. I don't think they can replace the state. And I firmly believe that the only legitimate agency that has the mandate for providing care to the population in most parts of the world is the government. And so therefore working with the Ministry of Health is extremely important. It's a question of at what stage you involve them. And many countries, the ministries are simply not ready to actually get engaged with mental health work. And often the NGO can play a critically important role in demonstrating in a smaller setting, in a smaller population, that you can do something with whatever resources are available on the ground. And so that's often what I find is what happens in most places is you demonstrate, you then engage, and then the government hopefully takes up the model.
I think most places where I've been, absolutely, you certainly don't want to be running afoul of whatever the minister or the ministry thinks is going to be a good idea, because that's one guaranteed way that you're going to have troubles down the road. So you want to engage people at the front end. I would say in this country, I'm not as sanguine about how much we can get out of working with the Ministry of Health. Nobody actually even knows who the Minister of Health is. It's really fascinating. And if you ask people who are in the health field here, who is the Minister of Health, nobody has a clue. It's very interesting. So people don't put too much, having said that, though, in mental health is a little bit different. 50% of, even though we have a relatively private healthcare system here, 50% of all formal mental health services are paid for by the government. Medicaid is a huge payer for traditional mental health services. And I think our ministries are in a lot of different places. They are not just at the federal level, they're at the state level, they're at the local level. King County Public Health does an amazing amount of good mental health work. So you have to think about where is the right kind of government level.
I have to make one snarky comment, which is I would say the other Ministry of Health here is our prison system, which is one of the largest providers of mental health services in the United States.
So this is kind of a more technical question, and it actually was for Vikram, but I think all of you could potentially answer this. In your work, how have you overcome various barriers to mental health care? So, for example, practical, psychological, cultural, in engaging and retaining depressed women in treatment?
Well, I mean, there are quite a few different barriers and therefore quite a few different strategies. But I'll give you an example of just the one that I'm dealing with right now. Of course, depression, disproportionately affects women, particularly in primary care situations. About 3 out of 4 people with depression in primary care will happen to be women, partly because there are more women in primary care as well. But one of the big challenges we faced is that the very nature of the treatment of depression involves multiple visits to the primary health center to complete the course of whatever psychological treatment you need to deliver. And if one took a psychological treatment typically from a manual in the West, the number of sessions that are needed are often, anywhere from 12 to 16. Consider, for example, interpersonal psychotherapy. So the real barrier here is often a practical one. Women can't come 15 or 16 times to the clinic over 3 to 4 months, because coming to the clinic involves enormous indirect costs in terms of time that's taken to get to the clinic, time off work, time away from other responsibilities, and so on. So our whole way of thinking about the treatment of depression in primary care is actually to rethink where, not just who delivers treatment. Of course, I've already referred to that. We actually model the use of other mothers, other women in the community to deliver treatment. But actually also the question of where do you deliver treatment? And so we've moved from a facility-based model of treating women with depression to a home-based model, which I think is it makes a lot of sense for those of you who work in the field of TB. That's exactly what the TB field has done. It's moved from asking people to come to the clinic to get their anti-tuberculous drug treatment to saying, we'll come to your house and make sure you take the treatment. It's just taken the mental health field a lot longer to discover that actually chronic care sometimes also means that we need to adapt the same ideas of home-based care for people with mental health problems. So here I've only addressed practical barriers, but of course, if time permits, we can talk about cultural and psychological barriers as well.
I'm going to give a little bit more of a local, just an example. We have a really wonderful program here in King County that is paid and funded by King County Public Health through a tax levy. So last time, remember when we all voted, every tax got voted down. There's one tax levy that didn't get voted down, which is money that King County Public Health spends on providing integrated mental health services in a whole network of community health centers, primary care clinic here in King County, to uninsured patients, to people otherwise have very hard access to health care. And one of the target populations is a group of high-risk moms. And we have served in these 14 clinics in the last couple years just over 2,500 of these high-risk moms, and we're getting fabulous mental health outcomes in this group. And this is not mental health specialty clinics. These are community health centers. And the moms are just blowing our socks off in terms of how much better they're getting, and we're sort of scratching our heads thinking about how come they're doing so well. And I think once you see that and the providers in the clinics see how much difference they can make, they talk it up with each other. The moms talk to each other, and they can engage each other. I think the other thing I will say is sometimes it's a very hard thing to convince an individual person to pay that much attention to mental health. And with a mom or with a woman, I can sometimes have luck by saying, can you do it for the baby? Can you do it for the rest of your family? Even if you yourself are struggling with, do I want to be tagged with this mental health problem?
I think what I would say is the work that we've been doing, we work in collaboration with local counselors. And these are folks who know their communities. And so rather than me trying to guess what would be a good way to deal with a barrier, we actually brainstorm with them. So for example, I'm thinking about your comment, Vikram, about getting women in. and the economic costs, we actually worked with the counselors to figure out when would be the best time to provide services so that we could have the women come in on market day because they were already close to the clinic and it was much less of a burden on the women. If we had tried to impose an external structure on them, we would be putting yet another barrier up. Similarly, one of the barriers that we encountered in Iraq was that if we had a female client and a male therapist, it was not appropriate for them to be in the room together and in fact could be unsafe for her in terms of her being seen as being engaged in dishonorable behavior. And so we leaned on our counselors to say, how can we fix this problem, help us think around this? And the solution we came up with was that she could invite someone else to sit in on her session, so a family member that she felt was safe for her to be in the room with her. That also now gives you another person who can help support the work that you're doing with this client. And that since she chose the person, we knew that the person who was in the room with her was someone who's likely to be supportive.
Okay, thank you. And the last question, until we open it up to the floor, is what role will technology play in rolling out mental health treatments globally?
I'll start with that one. We were just talking about some of that. I mean, I think I love technology. I've got a whole line of research that's playing with tech toys, and I am the person who's playing with my phone all the time, typically. I think technology has a lot of promise, and I also think it's important not to overpromise. So, for example, the National Centers for PTSD have beautiful, lovely iPhone apps that are free, that teach, they're based on empirically supported principles, and they've got quick relaxation strategies, PTSD treatments that you can download for free on your phone. Okay. They've also got ones that are developed to support therapists who are using these treatments. And the thing for them is, typically we were talking about nobody wants what we have to offer. They've had something like 200,000 downloads for this PTSD application, which is amazing. So people want that. Okay. I think the problem is localization is hard. And we first of all don't know that those applications work now. Nobody has tested yet whether those are effective, which is a little scary when you think about 200,000 people have downloaded it. But also we don't know how well it works when we move it someplace else, because that's a big change. And I think about the work that I do when I'm doing these adaptations and the trainings, and it's a dance, it's a dialogue. It's not me imposing something from outside. It's a collaborative endeavor with my clinicians. Who live in Iraq or live in DRC or live in Kenya. I couldn't imagine just coming up with that. I also think that often we are making a lot of assumptions about the level of technology that exists in some places in the world. In DRC, one of our issues is that there was no cell phone grid that was actually reliable. So if my therapist had a suicidal patient in the clinics that were in the furthest out areas, they couldn't necessarily call a supervisors to find out what they should do. So technology is lovely. It has a potential to increase reach. Vikram and I were just talking about there are more web-based trainings for clinicians, right, that are available. That might be a great way to learn some of these treatments, but they haven't necessarily been developed for someone who has an 8th grade education. And so I think there's tremendous potential, but there needs to be a lot of thought about what this will look like when we move it out into other places in the world.
Just add a little bit to that. I'm not terribly technology savvy, but I'm deeply impressed about this potential as well. And I'm going to say this. It's true that you didn't have reliable cell phone access at all times for your therapist, but 10 years ago, people in this place where you're doing this work didn't know what a cell phone was.
Yeah. And we use Skype to talk to them
Right?
every day. Yeah.
So, we don't have to go that much far ahead to think about how fast things really might change. Just fascinating in a way. And I think it's actually the next generation that's going to teach us what you could use the technology for. I see my daughter way in the back there. And I bet you she's going to be much savvier at, she's a student here, so now I'm going to make her feel blush, sorry. She's much better at telling me how to deal with technology than anything I'll ever do. But there are lots of cool things you can do with the internet now. You can take training anywhere in the world that has internet access. You can take quality improvement and supervision anywhere in the world that has internet access. You can take yourself anywhere. 15 years ago, we were doing telehealth consultations to rural primary care practices in our 5-state WWAMI region. We were doing what we thought was incredibly sophisticated at the time, using very, very complicated, sort of high-end, very expensive technology, and it was really hard because I would ask a question to the patient in a little primary care doctor's office in Idaho, and the technology had a 1-second delay on the video compared to the audio, and the human just doesn't deal with that because I would make a joke, and the person would sit on the other end with a stone face, and I'm like, oh, it's not going well. And then they'd start laughing when I'd gone on to my next sentence. And that 1-second delay was making us all so crazy that we didn't really use it very much. Now, who has Skyped with their parents at home if you're a student here? Everybody, or maybe not Skype, maybe something way better than that now. And if you're a grandparent, you've Skyped with your grandchild. We now have psychiatrists who can take, and sit in their office and who can Skype with a patient in a little small rural village, Alaska Native village, on the coast of Alaska somewhere, in a place that has no road access. And they can do a wonderful psychiatric examination, with the person there holding an iPad. That's just stuff you couldn't imagine a while ago. And in fact, for us in mental health, that's not so bad. We don't have to touch a person to examine them. In fact, maybe we shouldn't touch them too much. But so there's lots and lots of neat things you can do with technology. And I think that it's going to be amazing. So I'm a hopeless optimist. You could probably tell now what we're going to be able to do.
No, I mean, I agree with Jürgen, actually. I think technology does offer us a chance to completely leapfrog. We don't have to go through the telehealth sort of step that you had to go through. We can go straight through to internet-based based technologies. I have to say, I myself only discovered last month how to use a smartphone, so I'm not exactly the most sort of technology-savvy person.
And I only got mine in December, despite being able to pull up.
I'll be doing a tutorial with the rest of the time.
It's going to bring us into the 21st century.
Okay, so that's it for the pre-submitted questions, but I think the best way to handle questions now from the audience is if you stand up and give your question, and then I'll try to repeat it through the mic. That way we don't have to...
I'd love to hear a little bit more about the World Health Organization Mental Health Action Plan. The question I have is, will it make a difference? And if so, how will it make a difference?
Well, I can't tell you for sure if it'll make a difference. I mean, the World Health Organization has made plans before that have disappeared in the sands of time. But I think with all these plans, one important thing is what is available in terms of resources for the World Health Organization's core team to actually implement that plan. And the way I understand it is that having had this mandate, which was unanimous at the World Health Assembly yesterday, they are now armed with the political agreement of all the nations that this is something that they have been commissioned to do. The next step, and I think it's probably a bigger hurdle now, is to leverage resources, financial resources, from the various donors who fund WHO to actually get this plan up and going. I mean, the World Health Organization's mental health department is minuscule. It's only about 8 or 10 people. So it's small. It's probably as big as 1/10 of Jürgen's department here in UW, if that. So it is a small group. They're very, very dynamic. And the WHO has enormous reach, not through its human resources, but through its imprimatur, the WHO name and all its country offices. So I'm quietly optimistic that this plan will act as a platform for us to be able to leverage new resources, but that is the key to actually putting the plan into action.
So, my name is Paul Freeman. I'm affiliated with the Department of Global Health. I got two questions, one of which is quite whimsical. But the first question is, I'm particularly concerned with developing countries, and there are a large number of people living in slums, etc. So do you see a role for preventative approaches using, community health workers and group counseling?
In terms of prevention, often the short versions of some of the interventions that we use actually can have very nice preventative effects. So, we haven't tested it, but one of the most beautiful gifts that I could have ever asked for was one of my therapists in Kurdistan. came over to me after the trial was done. And he said, I actually want to start doing this intervention with the men in my village who are not trauma exposed, they're not torture survivors. I want to do it to start preventing gender-based violence in people's homes, because I think that these skills that I've learned how to use as a therapist would actually help people be less likely to abuse their wives. Now, I have no idea if that's going to work. We have no data around it, but what an incredible, hopeful, optimistic message around prevention, right? And that's something that's coming from one of the counselors where he really sees potential around that. I mean, we have data here that the interventions that we use do prevent violence re-exposure, that they can prevent problems downstream. But to me, that seemed lovely as a locally grown idea as well.
I think a lot about these, and some things I've read about slums, not just slums in Kenya. There's a lot of these young mothers, single mothers, who, they need to get support from older mothers, etc. So I'm thinking about this ongoing type of thing, using community health workers and other people.
Well, and, for example, interpersonal therapy has been used to help in terms of depression and prevention. So to me, this absolutely makes sense. There's data behind it. I think, again, it's a place where we just need to get folks out into those communities.
My other question, which is quite a whimsical one. I've seen on TV these things about happiness now. Some British guy, Holden, who supposedly ran a course in England, which over 6 weeks, which actually improves the happiness of people. Supposedly, according to the books, they use psychometric text to demonstrate this. Is there any truth or validity in that, and has it got any wider use?
So, this is an interesting question. It's not that whimsical, actually, because actually the word happiness has now become a very sexy word, and it doesn't come from the mental health field. It comes from the field of economics and development. So the biggest proponents of happiness are not people like Jürgen, Debra, and me, but people like Jeffrey Sachs in Colombia. I think some of you may know that they published the World Happiness Report last year, and there was no mention of the word mental in the entire volume. Didn't exist, except environmental. I did a search. So I picked up environmental all the way through, but no mental. So The Economist's view of happiness excludes mental health, which is, I think, a very interesting perspective altogether. So I don't know about this particular British intervention for happiness, but I think that following this new-found interest in happiness that is outside the health sector, I won't be surprised if there's going to be many new entrepreneurs who come up with ways to improve individual-level happiness. The second World Happiness Report, I should tell you, is going to be released in October this year, again by Jeff Sachs in Colombia. This time around, they have acknowledged that actually there is a mental health element in happiness. And so there is now a chapter that I'm involved with in writing on happiness and mental health. You'll have to wait to see what I've written to make sense of that.
Yeah, I guess I would have one caution as a psychiatrist. I think it's a fabulous thing to think about happiness, and cultures who can think about it in an organized way about how become more happy or how happy are they, that's usually a good sign, because that's not something that's a big part of the dialogue in a lot of cultures that are really struggling. But I guess what I would say is I don't think we can, with a pure positive psychology, happiness approach, help everybody who's struggling from really, really severe mental health problems. A person who has serious depression and post-traumatic stress disorder, doesn't matter how much they read and hear and think and watch movies about happiness, you're going to need some other interventions too. Just to be cautious. It's not going to be a fix-all answer. There's really only one person in this country who can, in a very brief intervention, kind of snap you out of whatever mental health problem you're in. That's Dr. Phil on TV. And I don't know if he's a licensed mental health provider, but so I'm being a little facetious, but he's not licensed? Okay, sorry. Anyway, now I'm going to get myself in a lot of trouble now. I just want to sort of caution, it's not going to be an answer that fixes all serious mental health problems.
My question was, I know that although the field of mental health has continued to grow the past 50 years, for example, it's what I've kind of been reading about is the treatment of psychosis through medications like clozine, and how the long-term side effects include actually more disability than what their illness has caused. And so I just want to know, as a group of experts interested in psychology and psychiatry, what you think of these long-term side effects and whether there is interesting and new research into preventing them.
Okay, so the question is about severe mental illness and your thoughts on side effect profiles from antipsychotic medications.
So I think, my own view on this is that, these concerns are actually very well founded. I think, as with all chronic diseases, the appropriate management or pharmacological management must include using drugs in the rational sort of way that includes the prevention of side effects. And it has to be said that often many of these medications are used irrationally, but that doesn't necessarily mean the medications are bad. It's the way they're being used that needs to be improved. Certainly the trials, and we've reviewed trials, a systematic review of trials for people with psychosis in the developing world, and it was just published actually this month in the British Journal of Psychiatry. You might want to look at it. And effectively, you find that there are profound social and clinical benefits to people with psychosis when they receive medicines. In fact, the one thing that predicts whether someone with psychosis will be able to return to work, which is a very important outcome for people in developing, well, anywhere, I think, is whether or not they're taking medication. So I think it's always a question with all these conditions, and unfortunately the medicines are not perfect. It's a question of finding the right balance between the benefits and the risks, and working very collaboratively with the patient to make sure that it's the right mix for that individual.
Yeah, I'd agree completely with that. I think that some of the antipsychotic medications we have available today have serious side effects. There's not a lot of abuse of those. They don't have much of a street value. So the balance between how happy they make you feel and the side effects is really on the bad side. So on the other hand, so what does that mean? We have to develop better treatments, and there's a whole bunch of people in this country and a whole bunch of NIH money going into trying to build better alternatives. Meanwhile, we have what we have, so we have to use the stuff we do have in a much more sophisticated way. And there is a lot of ways in which we can use medications, in a better, in a smarter way, lower doses, thinking about what else you can do to help the person who has to take a medication like that, function better. But I agree with Vikram. There are some chronic psychotic conditions where, having an antipsychotic medication makes the difference between a person living or dying or being able to work or not to work. So it's not a simple answer. A sort of a very simplistic answer saying these things are all bad, nobody should have them would really set us really far back.
My question, it seems to me that in terms of global mental health, at least my experience in our place here, there's a lot of issues about evidence-based practice. And if that practice may not be evidence-based, there's a question as to its effectiveness, whether in our immediate environment here towards ethnic minority or special populations. My question is that how do you see the developing countries provide in exchange what's been evidence-based practice there in their own culture to a developed country, and conversely?
I hope I don't have trouble repeating this into the mic, but please correct me if I'm wrong. But the question or point for discussion is around evidence-based treatments and us promoting evidence-based treatments that haven't necessarily been evidence-based in the country where we're working. And has there been any movement to give an evidence base to the local culturally sensitive treatments that have traditional medicine treatments that have that are present locally, and making them evidence-based and implementing them in this country? Yeah. So the reversal.
Yes.
Yeah.
So first of all, I think I want to highlight actually something that you said, which is that when evidence-based just means that we tested it and it worked. There's nothing magical about that, and anything could be an evidence-based treatment once somebody actually does a trial and demonstrates that this is something that is safe and effective. To a given population, absolutely, absolutely. And it doesn't necessarily, that doesn't always necessarily mean that it is going to be effective when you move something to another population. The other piece I would say is that that process has to be something that is iterative and is done by that community, right? So the work that that I did in Iraq and Congo, I actually didn't make the cultural adaptations. So as we adapted that therapy, that work was done by the counselors because they know their culture, and I don't, and I will never know their culture in the way that they do. Okay? And that's what we tested to see if it was evidence-based for that community. And sometimes it works and sometimes it doesn't work. Okay? The other piece is we were not just testing these therapies, we were testing things that had already been developed in the community and that were being used there to see whether those are also evidence-based. Okay? And again, sometimes that's true and sometimes it's not true. Sometimes what someone may be using is not effective, but no one's ever tested it. One of the therapies that was being used in Dahuk, in the Dahuk region, was developed there, and it was actually very effective. It worked quite well. The other piece I would say is that that then should come back and inform care here, and I agree with you. I think that this is a bi-directional exchange. Some of the work that we did in DRC is now coming back and infusing some work that we're doing with Native American communities here. So.
Can you give an example?
In terms of, I actually can't talk about that project because I don't have the community's permission.
So this is a great question, and it's a really complicated issue. You know, the published research evidence on any treatment for any condition is never done on the person that you have in front of you when you're a practitioner. It's done on hopefully a good enough, representative enough, large enough sample of people where you can conclude from that on average, whatever this treatment is worked better than whatever the control condition was. But that's never the person in front of you, right? So that's the average evidence that you have available in the literature. The ultimate evidence that matters is what's the evidence for that particular individual you have in front of you. They write their own evidence, right? But now, of course, knowing nothing, if you don't know that person's evidence yet because you're just starting to work with them, you have what's out there on average. And so there's a huge gap between that. And I guess my sense of it is, if we said just because a treatment hasn't been tested on every subpopulation of human beings, it can't be helpful because it wasn't tested on this group. There's also a disadvantage from that because oftentimes the research evidence is generated on people who are not your sample that might be in a situation where they're never going to be in a trial or it's harder for them to get in a trial. And if you said just because we haven't tested on this subgroup, it surely can't work on them. They could actually be disadvantaged by that. So I find that a really interesting challenge. I do think that on average, people are more alike than they are different. That's just my personal bias. And so if something worked really well for another person or another group of people, even though it may not be this particular group, I would certainly give it a lot of consideration if I have no other information to go by. But then you have to look very carefully about what are people doing now. And people are, these are common problems for which humans have had organized responses of one type or another for a long, long time. And I would say I'm a scientist. And even with an individual patient, I think like a scientist to say, let's see if it works. If there is a better alternative, let's look at it. Let's take a good look at it. It's not magical. I mean, it's very easy. The patient either gets better or they don't. And if whatever their local alternative is, it looks like it works, it makes a difference, no need to try to impose something else. If it looks like it really doesn't work, now I have to get into a process of saying, what is the evidence that I do have help me? How could I shape treatment? How could we adapt it? And then you work together with people in the community that you have and say, what is going to be the evidence for your group? So a long-winded answer, and I think it's a very complex process to do really well.
Yeah, I think one of the things I want to just echo what Jürgen just said. We've just completed another review looking at the kinds of adaptations that intervention psychological treatments had to undergo for use in populations, either ethnic minorities in countries like the US or in non-Western countries, and what was the effectiveness of those interventions, specifically looking at depression. And the two main headline findings were that they were following adaptation, the effect sizes were just as the same as the original populations in which they were actually tried. And secondly, that the adaptations actually were not structural. They were tended to be quite, like, for example, changing idioms and metaphors, which you would expect to do anyway in practice. Any good therapist would be hopefully culturally sensitive enough to be for making those sorts of adaptations. There were no structural or theoretical changes to the treatment. So that paper will soon be out, and I think it really sort of pretty much confirms what Jürgen has said, and something which I never thought would be the case. So it does actually, in my mind, it does represent a very important step ahead, a step forward in thinking about the universal application of psychological treatments. But I think you're also pointing to something quite different. Your question is actually quite a broad question, and it's also about what constitutes evidence and whether we do have a fair representation of evidence from different cultures, which is a different question to the one that I think we've just addressed. And I think in that sense, we don't. Every psychological treatment we have has come from basically one culture. The fact that it works in other cultures is great news. But the fact that we don't actually know anything about the psychological approach that other cultures have used is a loss to mankind, because we actually have no reverse flow of knowledge. Where people have made observations in other cultures, for example, the incorporation of Buddhist meditation in the form of mindfulness or dialectical behavior therapy. Where that has happened, you've often found new versions of treatments that have either been more potent or useful in specific groups of patients. So we do have proof that when you do take practices from other cultures, you can actually expand the range of treatments. And my own view on this is actually what we need is a very major research enterprise to actually do more of that kind of work, to actually explore what communities in other parts of the world have done historically for managing mental health problems. They haven't waited for psychiatry. They've obviously been doing things for generations, and to actually characterize them and then to test them in exactly the same way as we test psychological treatments. My belief is that we probably come up with a fairly new range, or hopefully a new range, of approaches that can expand what I think is still currently quite a limited set of approaches that we can offer.
Thanks. Please excuse me. I know I'm not a member of the expert panel, but I just had to mention one thing. I work with...
You are also an expert on this.
Yeah, I don't know about that. The ICRW, the International Center for Research on Women, developed a stigma reduction toolkit for around HIV stigma, but some of the same principles can be applied to mental illness-related stigma. They developed this toolkit in 5 countries in Africa and have translated it and used it in other countries throughout the globe. And that particular toolkit is available online at the Gay Men's Health Crisis website and other places, including the ICRW's website. And we have taken that toolkit and adapted it for African American women living with HIV. So we've taken this kind of locally developed toolkit and used it here in the U.S. with some promise. It's now in a larger trial, so we'll take a look at its effectiveness. But I think that this is just one of many. As we do more global health work, we're discovering these kind of more locally developed treatments and bringing them back here to the U.S. So it's an ongoing process as, this area of global health research, becomes larger. We bring back things to our home countries. Yeah, it's about 3, and I know Vikram has to catch a flight back to London. India. Oh, okay. Long flight. So thank you very much for coming, everyone, and thank you, panelists.